recording. Okay, so I want to start off by asking you guys if you have any questions before I get started today. Everybody doing well? No questions? No concerns? I'm going to take. Yes, Carrot.
Yes, I just have a question. So based off of like coming to lectures and things like that, do you have any advice as to how to prepare for the exam?
Yeah, I'm glad you asked that. So I know that last time or whatever day we met earlier this week, somebody asked, and I think it was you, Carrot, about whether I was going to ask pathophysiology on the exam. So, you know, pathophysiology is always going to be part of your life, of your career. And in order to understand the disease processes, in order to understand why you're doing the treatment modalities that you're doing, the medications that you're giving, you need to understand the pathophysiology. So will it be direct? Will it be a direct question? Probably not on the examination. Now you can see in the weekly quizzes, some of those questions are very direct. And I wish I could think of a direct question off the top of my head, but I can't. But in those weekly quizzes, you'll see more direct questions. And I can really specifically think about that when you get to the dysrhythmia quiz. Now, I guess really what I want to tell you is that in order to be successful, you have to have that foundational knowledge, and that's what I try to give you every time that we come together for our live sessions, is that foundational knowledge so that you can hopefully understand what's happening in the disease process. Once you get that foundational knowledge, then I would go out and I would test myself and make sure that I really can apply, because everything in this course is about application. I have this foundational knowledge. Will I be able to take that foundational knowledge and apply it to patient care? And so that's what I would want you to do. So I recommend that you read Lewis, that you do your study guide, and that subsequently you will test yourself either using ATI, Evolve, or any other NCLEX book that you may have in your possession. So I always recommend that when we get closer to the exam or at the end of every module, whichever works best for you, that you begin testing yourself. Now, my personal thought is that Evolve has some higher order questions, and that if you are able to pass the Evolve questions, you probably have a pretty good understanding. And even if you aren't successful on those questions, at least you have the rationale. Does that answer the question?
Yes, ma'am. I think what you're saying is it's kind of like, when you teach a person to fish, you want us to have it as a basis for a lifetime, and just apply what we learn and also add to it by doing questions. But you're just trying to give us a baseline. So I get it.
Yeah, because you could go to the ATI book and you can do the cliff notes, but you're not going to get a good understanding. And in my personal opinion, you just can't memorize this stuff. There are some things you have to memorize. You have to memorize how blood flows through the heart. What are the structures of the heart? You have to memorize those kinds of things. But then you have to use critical thinking when it comes to trying to apply that information to your patient. Like, what is actually happening with the patient, and how are we going to fix it? What are the interventions? What are my evaluation? What are my teachings? And then you'll have to bring some of that stuff with you that you already learned, because we can't go back and relearn it. So that's why I had you guys do the heart failure ATI last week, because I want you to clear the cobwebs, so to speak. Okay. If anybody and anybody can reach out to me if you want some one-on-one time with me to talk about whatever your individual needs are. All you have to do is reach out to me, and we'll schedule a time on Blackboard Collaborate to meet. Okay. I'm very open and I'm very accessible to you. Okay. We'll just schedule something that works for both of us, as long as we're all patient. So I want to remind you that coming up this week, you have due on the 22nd of May, you're going to have your valvular disease, heart disease quiz that's in Blackboard, and then you'll have ATI fluid and electrolyte balance, or fluid and electrolyte teaching, and that's just to refresh your memory, okay? Any other questions before we start today? Okay, let's get started. So we're going to talk about valvular heart disease, and let me get it up here on the screen. There we go. Now we're ready to go. Okay, so these conditions, the conditions that we're going to be talking about today are either a result of a defect of a valve or a damage of the valve. Now, this damage or the defect can happen to any one of the 4 valves that we have. And it can be, that damage can lead to a narrowing of the valve. It can lead to a prolapse of the valve because because the leaflets don't sharply close together, and that will lead to regurgitation. And so that's where we're going to talk today. And we're going to mainly talk about I'm going to say the most important 2 valves. Which are the most important 2 valves? Have you in your learning? Do you think they are? Mitral is one, and aortic. Okay. Anything on the left side. Remember, the left side is the most powerful. So mitral and aortic are the things that I want you to concentrate on, and I want you to know that. Tricuspid and pulmonary valve issues do occur. They are less common than mitral and aortic valve. We're going to touch on them, but we're not going to spend a whole lot of time today talking about tricuspid and pulmonic valvular disease. And I do want to remind you that, again, we are still talking about perfusion here. Whenever we have a valvular issue that's causing the patient problems, we're always concerned about whether or not the patient is receiving adequate blood supply. So perfusion, we're still under the umbrella, the concept of perfusion. So, you know, just like just about anything, not all things, but things that are genetic, but there are a lot of things that we can control. And I want you to go back and I want you to think about all of your education that you've had thus far in cardiac, and about what would you teach your patients to prevent cardiac disease. Sometimes we can mitigate and modify disease processes just by doing what we're supposed to do. So weight management, obviously, having an appropriate BMI, a healthy diet, and that depends on, you know, what's going on with you. What does a healthy diet mean? If you don't have any health concerns, it surely means a minimum of 5 fruits and vegetables, servings of fruits and vegetables per day, having lean meats, incorporating more plants into our diet, aerobic exercise 3 times per week. And that doesn't mean you have to, you know, run 10 miles. It means that you have to get your heart rate up for at least 30 minutes 3 times per week. And then remember, and I don't have to tell you that we all know that our myocardium is a muscle, and it's like anything else, it needs to be exercised and it needs to stay strong. Lipid management. Lipid management is super important in heart disease. So what am I specifically talking about? Total cholesterol. Well, total cholesterol comprises HDL and LDL. So LDL is our bad cholesterol, so we want to keep that under 100, and we want our HDL to be high. And how do we increase it? How do we tell our patients to increase their HDL? How can they increase it? Do you guys remember? How do we increase our HDL? Diet. How about exercise? Exercise increases our HDL, our high density lipoprotein. And the high density lipoprotein can carry the bad lipids, or the LDLs, out of the body. It helps to rid them. So we want ourselves and our patients to have a high HDL. If you're diabetic, oh gosh, we know how much havoc that sugar plays on our vessels. So we need to have a good control of blood pressure and a good control of diabetes in patients who have those underlying conditions, and stress management, because when we're under a high amount of stress for a long period of time, remember that our adrenals are going to secrete catecholamines, adrenaline, epinephrine, which adrenaline is epinephrine and norepinephrine, and that causes us to have a constant inflammatory situation going on, which is not good. So think about how you're going to talk to your patients, how you're going to teach them about, let me shut my phone off, how to keep themselves healthy, how to maintain good cardiac health. And then if they do have cardiac disease, then you need to be thinking about cardiac diet. Our patients that have heart failure as a result of, let's say, valvular heart disease, they're going to be more than likely on a low sodium diet. And so that is like very important in teaching our patients about low sodium, because in our society and the way that we prepare foods in the United States, if you are getting foods that are packaged, if you're getting things that are processed, they're very high in sodium. And a lot of people think that when you're talking about low sodium, you're just talking about adding salt at the table or adding salt when you're cooking. They don't think about the amount of salt that is used to can vegetables, or maybe soup or lunch meat, or anything that's packaged and processed. So think about that. Any questions so far? Okay, so I want to just touch on this very quickly, because I think that this is super important for you to understand. So in cardiology services, we have many different, I'm going to say, branches or subspecialties of cardiology is a better subspecialty is a better word. So remember that your cardiologist, who you're going to call in the hospital when your patient has a heart condition or a heart problem, they actually are boarded in internal medicine, and they have a residency in cardiology. So those individuals are going to deal with, you know, they're going to deal with your heart issues, heart failure, dysrhythmias, anything that has to do with cardiac disease. Now, those individuals can also have another certification where they can do interventions. So when I'm talking about interventions, I'm talking about taking a patient to the cath lab. Most of them, all of them can do a left and right heart cath, for example, but can they intervene? Can they deploy a stent, for example? So there's your interventional cardiologist as well. And then, of course, you know, you have your CV surgeon. They are surgeons, and they're going to work within the cardiopulmonary subspecialty. And then we have electrophysiologists. You guys know what the electrophysiologists are? You guys know what the no, you do. All right, Mo, tell us what they are, what they do.
They study the heart and it's checked to see what is causing, like the history of the heart, and see what's causing the heart to function the way it's functioning.
Yes, so they're dealing, very good. They're dealing mainly with the electrical component of the heart. So what is causing that dysrhythmia? And is there medications that we can use, or are there procedures that we can use to correct the dysrhythmia? So that is, for us, that will be module number 4 when we talk about dysrhythmias. And the electrophysiologists have a specialty in cardiology, electrophysiology, that deals with rhythm issues. So I want you to understand that it's not one size fits all. There are a group of people who will take care of a patient with cardiovascular disease most of the time. Okay, very good. Okay, so this is just a review slide for you. If you don't know it, this is the time that I want for you to know it. I want for you to go back, and I want for you to memorize. You won't hear me say that very often. I want you to memorize how blood enters into the right side of the heart and all of the structures and the valves that it goes through and how it exits the left side of the heart. I want you to memorize that. Once you memorize the forward flow and you have that down, then I want you to work backwards from the aorta and going back down to the left ventricle and working backwards, because when we're talking about valvular heart disease, most of the time, if we're not talking about stenosis, if we're talking about regurgitation, we're talking about retrograde flow that's going backwards. And on day one of these lectures, I told you that blood should always flow forward. It's one way. It's not a two-way highway. It's one way. So it comes in on the right side, goes through the process, and goes out the left side. But if we have regurgitation, then we know that blood that has gone forward is going to retrograde, or it's going to flow backward into the previous chamber. Okay, so I want you to understand structures, I want you to know your structures, and I want for you to know your blood flow. Now, down here on this particular slide that I chose, or image that I showed, what are these structures that are down here? These little, they look like roots from a plant to me. What are those? What are those structures? They're like important. They are like the spring. Okay, so I want you to look down on this image slide, down at the very bottom of the ventricles, where you see these little shoots of tissue that they look to me like they're a root of a plant. Okay, they're the chordae tendineae. Very good. So Brandon, tell us the purpose of a chordae tendineae. Why are they super important?
Yeah, so I think the papillary muscles contract and they pull on those to open the valves and close them.
Very good. So the chordae tendineae are buried in that papillary muscle. Okay, so they're anchored down into that papillary muscle, and they act like a spring door on your screen door. They act like the spring on your screen door. So they're going to stretch to open, and they're going to contract to close. All right. So they're very important. They apply the tension that's needed to make sure that the valve opens fully and closes tightly. So they're very important. So if we have some kind of an issue where the papillary muscle is disrupted, it can release the chordae tendineae, and then we have a big problem. So that's very important for you to understand, to be able to understand some of these like acute situations in mitral valve regurg, for example. So it's important for you to understand the structures of the heart. So if you need to go back and refresh your memory, please do so. Okay. Which valve or valves are comprised of 3 leaflets? So the number 1 is tricuspid, number 2 is tricuspid mitral aortic, number 3 is tricuspid aortic pulmonic, number 4 is tricuspid pulmonic and mitral. Sorry, that's cut off. I'm going to go over here to the chat box. So who agrees with Kara? Who agrees with her? Which valves have 3 leaflets? Don't be Googling it either. C. Who agrees with Mo? Yeah. Okay, so C is correct, and a lot of people we forget this. Okay, so I mean, I think we just kind of take it for granted. So mitral is the only valve with 2 leaflets. Everything else has 3 leaflets. So tricuspid, which is obviously tri, means 3, aortic and pulmonic, they all have 3 leaflets. And you know what? Remember that this is a safe place. Say what you think. I want you to stimulate you to think. Sometimes when we get things wrong, that's the time that we actually remember. So bicuspid or mitral, and very good, Brandon, for bringing that up. Bicuspid and mitral are the same thing. Okay, bicuspid and mitral are the same thing, and that's why people get confused, because we have multiple names for things. But mitral valve and bicuspid valve, and bi means two, are the same valve. Okay, let's hope this slide's not messed up. Okay, which valves are considered the atrioventricular valves? What are the AV valves? And Brandon, why are they named atrioventricular? Yes, because they separate the atria from the ventricle. All right, so they sit in between. So obviously the semilunar valves are going to be the aortic and the pulmonic valves. So we have lots of terms. Some people will say mitral and tricuspid. Some people will say AV valves. Some people will say pulmonic aortic. Some people will say semilunar valves. So that's why it's important for you to actually be able to go back and forth. And if you know your valves, that won't be an issue for you. Okay, so make sure that you learn those things. Am I going to try to trick you on the test with those terms? No, but sometimes you might not know what somebody's talking about. Okay, so this is just what I just told you right now, and it's just a further breakdown. Remember, valves are one way. There's not a two-lane highway. Remember which valves are left and which valves are right. Okay. Heart sounds. When auscultating the listening points of the cardiovascular system, S1 is defined as that's correct. So it's the closing of the mitral and the tricuspid valves. It's never the opening. You cannot hear the opening of any valve. S2 is D, the closing of the aortic and the pulmonic valve. So S1, mitral tricuspid, S2, aortic pulmonic. That's why when you are using your stethoscope and you are auscultating somebody's chest, that's what you're listening for. Remember, I don't know what you guys say, but I always teach all pigs eat too much. Okay, aortic, pulmonic, herbs, tricuspid, and mitral. Those are the listening points. That's where you hear S1, closing of mitral and tricuspid, S2, closing of aortic and pulmonic valves. Now, if you're going to be able to identify that. Those are things you have been listening to now for a year, going on a year and a half. But there are going to be some other heart sounds that are going to take some time for you to be able to differentiate. And here I'm talking about S3 and S4. So what is S3? Okay. What is it? What causes an S3? What's one of the most common causes of S3? Increased pressure, right? And usually it's because of fluid volume overload. Okay, so it's a gallop. I hear it as a gallop, and you can really hear it if you have a patient, for example, who's in shock. It's not a murmur, Brandon. We're going to talk about that. So yes, like in heart failure, you will hear an S3 after S2 in your patients that are fluid volume overloaded. Okay, so that is that's probably the one you're going to be able to distinguish before you're able to distinguish S4. S4, okay? But the most common cause is fluid volume overload. So mitral insufficiency. So you're going to have less flow, okay, to your mitral with insufficiency, right? Because we're talking about a stenosis. So, but there is increased pressure, but it's usually caused increased pressure from volume. So I just want you to understand the other heart sound. So S3 you hear after S2. What is an S4? Do you remember what an S4 is? It's that kick. It's that kick, the Tennessee. So is that how you guys learned it? Like that's what you're telling me that you hear? You hear Tennessee when you're listening, or you hear Kentucky? Explain that to me because I don't know that. Teach me something today.
That's the way I learned it. So
Okay. So tell us, what do you mean by that, Mo?
so it's like, so when you hear like S1 is lob, S2 is dub, right?
Yeah. Did we lose you?
I think you did. So I think so. S4 is before the S1, so it's like a tricular gallop. So you
Yes.
hear Tennessee from that.
Okay. Okay, and you're right. It is something that you hear before S1, and S3 is what you hear after S2. So I guess I'll have to use that little trick next time I hear that sound. So you hear Tennessee before S4, and you hear Kentucky after S3. Are we correct in understanding it correctly?
Yes.
Okay, so very good. Thank you for sharing that. I mean, that might help a lot of people, but I must tell you, learn to distinguish S1 from S2, and then if you hear something that deviates from that, sometimes you might need some additional help learning those sounds because it's difficult. I'm not going to lie, it's difficult. So what is a murmur? Brandon says murmur. Brandon had said murmur. So I want to know what is a murmur? What's the definition of murmur? Turbulent blood flow through the valve, right, Mo? Through the valve. So it's turbulent blood flow. So are we worried when we hear a murmur? It's not an irregular beat, Carrot. It's turbulent. It's that whooshing sound, whooshing sound. And yeah, it depends. It depends. So there's innocent murmurs versus pathologic murmurs. So an innocent murmur depends on whether they've had their whole life and it causes issues or not. Yes, whether or not patients are symptomatic. Is a patient symptomatic or not? So I want you to be thinking about that. When you hear a murmur, you might want to ask the patient, have you ever been told? Don't tell them that you hear a murmur, just to ask them, have you ever been told you've had a heart murmur? That's a good question to ask. If it's new, definitely needs to be reported. Definitely, probably in an adult, will need to be worked up. Okay. So, and it's kind of weird. Some of the murmurs that you find in adults, they do happen. Okay, this is this is what normal looks like. I always think that you need to know normal so you can recognize abnormal. So we always want that valve to open to its fullest capacity to let all of the volume out. And when it snaps closed, we want it to close very crisply and tightly because we do not want blood flow to go back to the previous structure. So this is what normal looks like. So we have some variations in normal, and today we're going to be talking about stenosis and regurgitation. So it can happen in either stenosis or regurgitation can happen in any of these four valves. And you can see by this image, this shows you that all of these valves have 3 leaflets with the exception of the mitral or bicuspid valve that has 2 leaflets. So tell me, what is stenosis? Tell me the definition of stenosis. It's a narrowing. It's a narrowing of that valve, right? So as a result of that narrowing, it doesn't fully open. It's stiff, right? It's stiffed or it's narrowed. So it doesn't fully open. So as a result of that, what's going to happen to blood flow? What happens to blood flow from the atria to the ventricle if the valve is stenosed? It's going to be less. It's going to decrease, right? So it's going the amount of blood that's coming from the atria to the ventricle is going to decrease, which will subsequently decrease our stroke volume, which will then decrease our cardiac output. And it's going to change pressures in those chambers, right? So stenosis can be not an ominous, but it can be a difficult. Yeah, it can be after about a third, when the vessel is decreased in size about a third, we start to see problems, or patients start to exhibit clinical manifestation. So what is regurgitation then? What's regurgitation? It doesn't close effectively. That's correct. So the leaflets aren't closing, and we have retrograde or backflow of blood from usually the ventricle to the atria, back to the lungs. For example, if you're tracing it from the left ventricle through the mitral valve to the left atria, through the pulmonary artery or vein, back into the lungs. Okay, so that's what's happening in regurgitation. So we have backward flow. So when we have backward flow, what kind of issues are our patient going to experience? Because we have blood that's on a 2-lane highway when there's only one lane. There's only one lane. Can have pulmonary edema, right? And we also have mixing. So what comes out of that left ventricle through the aorta to the body is purely oxygenated blood, right? It's purely oxygenated blood. So now when we have mixing of blood, then we have a mixture of oxygenated and deoxygenated coming out of that aorta, right? So there's lots of issues, okay, that can occur here. All right. And I think you'll be able to answer this question. Oh, we already did that question. Sorry. Okay, so here's exactly what we just talked about. So I put down here at the bottom, I should have put a question mark, not an exclamation point. But this is going to, depending on the degree, depending on whether it's acute or chronic, this is going to change the quality of your patient's life. Okay, it's going to change their quality. So we're going to have to think about treatment and all those kinds of things that are going to help improve quality of life. Okay. Why, this came directly from your study guide. Why are valve issues on the left side of the heart more serious than the right side? Why are they? Exactly. So what is that? What's that concept that we've been talking about all this time? Yeah, it affects perfusion, right? Remember that the left side is the strongest side. It's the thing that really keeps us going. Of course, not that the right side isn't important, because if deoxygenated blood can't get into that right side, then yeah, there you go. So that's right. That's right. You guys got it. So it's going to affect perfusion. And then you have to think about the seriousness of the disease process. And if that seriousness is exacerbated, your patient can go into some sort of shock, right? Because if that issue is not treated, and especially if it's an acute situation, your patient can end up in cardiogenic shock. So that's why in cardiogenic shock, it wasn't only the highest propensity is those patients who have an acute MI, but also valvular disorders are on that slide if you remember. Okay. So we're going to talk about mitral valve stenosis first, and remember that this is always occurring on the left side. So be thinking about the left side when we're thinking about mitral valve stenosis. So rheumatic heart disease, that's really what I mean here is I mean rheumatic carditis. All right, so rheumatic carditis is an infection that happens because of streptococcus, beta hemolytic strep, that usually happens when you have strep throat. And so there's this autoimmune response that happens to patients, and they develop something called rheumatic fever. So that inflammatory process can have a long-term effect and can damage the valves of the heart or the heart itself. Okay, so rheumatic, so you might think strep throat, oh, what a big deal. That's not a big deal. It is a huge deal, because if that is left untreated or partially treated, it can become a systemic infection and it can affect the heart. So I want you to be thinking about that. I want you to be thinking about just even yourselves or anybody that you know or any patients you're teaching for patients with strep throat, like any other patient, is that they need to take the full course of antibiotics to make sure that they have cleared that infection, because we don't want them to have long-term damage to their heart or to their heart valves as a result of an infection that could have been cleared with appropriate treatment. Sometimes it's congenital. It could be an atrioventricular defect that a patient is born with, where they might end up with a mitral valve stenosis. Lupus, which is an autoimmune disease, which we're going to talk about at the towards the end of the semester, can also result in mitral valve stenosis. And in these autoimmune diseases like rheumatic carditis are inflammatory in nature. Also, patients can get mitral valve stenosis if at the base of that valve, which is called the annulus, if they develop calcium deposits around there. That can also lead to a stenosis. And anybody who has ever had radiation to the chest, that can also cause a mitral valve stenosis. So here what's happening, the mitral valve, of course, is located between the left atria and the left ventricle. And it's providing, obviously, what we already talked about. It's providing oxygen to the body. And the mitral valve is the gatekeeper between the left atria and the left ventricle. So when we already established this, that there's going to be a decreased blood flow from the atria to the ventricle, blood volume will be decreased. And then pressures are going to increase in the pulmonary system, because we have that retrograde flow from the left ventricle, from the left through the mitral valve to the left atria back into the lungs. So your patient may have pulmonary edema, and we're going to talk about acute mitral valve or regurgitation and how important that can be. That is a medical emergency. So potential complications, of course, we can have heart failure. And so that's why I want you to make sure that you know your signs and symptoms of left and right-sided heart failure. So what would you see in your patient with left-sided heart failure? What are some of the signs and symptoms that you're going to see? Pulmonary edema, pink frothy sputum, yes. Shortness, dyspnea, shortness of breath. So shortness of breath, so let's say dyspnea and tachypnea, right? Difficulty breathing, increased breathing, crackles. You could have an S3 for sure, Mo. You could definitely have an S3. So you're going to see pulmonary edema on a chest x-ray. What do you think about this heart? What do you think about this heart here? What do you think about it? It's enlarged. Yeah, it's enlarged. So what do we call an enlarged? What's the medical term for enlarged heart? cardiomegaly, cardiomegaly. So that's an enlarged heart. Your patient can also develop a dysrhythmia. The most common dysrhythmia is, do you know? AFib. Very good, Mo. AFib. Atrial fibrillation. We're going to talk about that in module number 4. And then, of course, if they have a dysrhythmia, they can have an increased risk for thrombus. This is something that's important for you to understand. If you understand it now, you're going to get it when we get to module number 4. So if your rhythm is not normal sinus and you have a chaotic rhythm, and in atrial fibrillation, your atria are firing really, really fast, but no blood is actually flowing through, or not no blood, but a decreased amount of blood is flowing through those valves. And so if that blood is sitting up in the atria and the atria is kind of quivering, then you have an increased risk for microclot formation, and you'll throw that thrombus, and it'll go to somebody's heart, it'll go to somebody's brain, it'll go to somebody's liver. Okay, so that's why you get a thrombus formation. Okay, any questions about that? Okay, so what are your clinical manifestations? And this is what I was talking about earlier when I was talking about listening to your listening points. I can't tell you how many times that I deal with this. I even deal with this with the medical students, where they really don't know where they're listening and they really don't know what they're listening to. Make sure as a registered professional nurse that you know what you're listening to and what you're listening for. You're listening for the crisp closure of those valves at S1 and S2. All right, that's what lub and dub is, and we shouldn't be really using those terms. Okay, so these patients are going to have some exertional dyspnea. So when they're active, when they get up out of the chair, go to take a shower, or just go out to eat, they'll have exertional dyspnea. So when they're exerting themselves, they're going to have difficulty breathing. They're going to complain of shortness of breath. They might become tachypnic. They'll have a very loud S1. So the closing of those valves, it'll be very loud, the tricuspid and the pulmonic valve. They could have a low-pitched murmur. If they're fatigued, think about AFib, okay? Because AFib patients have a decrease in cardiac output, and they will also have palpitations as a result of decreased cardiac output. We already know that they could have some hemoptysis or bloody sputum. They can also be hoarse. They can have chest pain, and of course they're at risk for a stroke because of the reason I just told you, because they're at risk for thrombus formation, especially if the patient has atrial fibrillation. Any questions about what your patient's going to look like in mitral valve stenosis, or what's actually going on? Remember, your blood is not getting down from the atria down to the ventricle, and it's not getting out to the rest of the body. So we may have a perfusion issue, because we're talking about the left side of the heart. Any questions? No? Okay. So now let's talk about regurgitation. Okay, what's regurgitation again? So regurgitation is backflow of blood secondary to non-closure or incompetent closure of the leaflets, and this happens during contraction or during systole. So blood is going to flow backwards. So the left ventricle and the left atria are going to have to work harder to preserve cardiac output. They're going to have to work much harder. And so when our heart works harder, what are patients at risk for? Atypical chest pain. What will happen to the muscle, Mo? What will happen to the muscle? That's what I'm getting at. I probably didn't ask that right. What will happen to the muscle if our heart has to work a little harder?
Weak.
What did you say? I didn't hear it.
It will be weak. It will be weak. Weak and also.
Yes. Okay. It's going to enlarge. It's going to cause hypertrophy. Brandon says it's going to enlarge. So that left ventricle is going to become hypertrophied. So this is a situation where we don't want that left ventricle to be any thicker than it's supposed to be, right? It's not like when you go to the gym and you're lifting weights and you want a nice bicep. That is not what we want to happen here in this left ventricle. What happens when the left ventricle hypertrophies? Why is that a problem? That wall is going to thicken. And what will happen to filling capacity? Yeah, it's going to not be able to hold enough as much blood. It's going to be less, right? So it's going to further complicate cardiac output. Very good. It's going to further complicate cardiac output, stroke volume, all right? Isn't that what causes the S4 sound? It can hypertrophy. Yeah, left ventricular hypertrophy. Yes, it can. So because you have that atrial kick in S4, you have that the atrium is trying to push out more blood. So that's why you hear S4. So yes. Very good, you guys. That's what I want you to be thinking about. Okay. Okay. All right, so let's talk about the risk factors for mitral valve regurg. Okay, so we're talking about those leaflets that aren't going to close properly. They're going to be incompetent. A myocardial infarction can cause that. So can chronic rheumatic heart disease, mitral valve prolapse. And then mitral valve prolapse is really, that's what happens in regurgitation. Those leaflets go back into the previous chamber. So in the mitral valve situation, they're going to fall back into the atria. Okay, so mitral valve prolapse leads to mitral valve regurgitation. And here's where we can have a problem. Remember, I told you, we talked about the chordae tendineae, we talked about the papillary muscle. Well, this is where we could have a problem. If there's ischemia to that papillary muscle, then we're going to have a problem, or a rupture of the papillary muscle. We can have a problem with the chordae tendineae, which applies that tension to the leaflets, all right? And infective endocarditis, which we are going to talk about next week, okay? Questions? Those are our risk factors. So we're going to talk about the difference between acute and chronic mitral valve regurgitation. So acute mitral valve regurgitation happens when there's like a sudden pressure or volume in that pulmonary bed, okay? And so it results in pulmonary edema, and if it's left untreated, these patients will progress to cardiogenic shock. All right, so this is a medical emergency. So your patient's going to have these clinical manifestations. They're going to have a thready peripheral pulses. They're going to be cool. They're going to be clammy. They're going to be gravely ill. They're going to be hemodynamically unstable. So they're going to usually require surgical, I should say, not medical, surgical intervention. So what kind of surgical intervention do you think we could do for this mitral valve that's not functioning and causing pulmonary edema, which could be a risk factor for cardiogenic shock? What could we do for these patients? A valve replacement, okay? I would agree with you that it would be a mitral valve replacement. What kind of valve would we use? What kind of valve could be used? Depends. Okay, we could use, okay, I like that. It depends on the age, and it depends on your age. So we're talking, that's a big factor, Zenaida. So it could be mechanical, but what other things could it be? What other type of valve could it be besides mechanical? What do we have available to us? Biologicals. So what's in the biological category, Mo?
bovine, right?
right?
Bovine.
What's the other one?
I said just I don't know bovine.
Bovine is cows, and
Okay,
porcine is from a pig.
yeah, pig, yeah,
Porcine
pig.
is a pig. All right. Yeah, porcine. There we go. So porcine, bovine, and then we have donor as well, right? We can also get some donor valves. So which one lasts longer, mechanical or biological? Mechanical. So which one needs to be anticoagulated? Mechanical. What kind of anticoagulant are we going to use? Warfarin. We're going to use warfarin, okay? That's going to be long term, okay? Warfarin. So remember about warfarin. Remember that warfarin is what I call a dirty drug because it interacts with a lot of things. There's a lot of dietary concerns associated with Coumadin. There's a lot of medications that we have to be careful about using in conjunction with warfarin. Our patients have to have what lab tests on a routine basis? What lab test do they have to have? A PT-INR, and we have to maintain their INR 2 to 3 times that of normal to make sure that they're effectively anticoagulated. So very good, guys. That's awesome. So make sure you know the difference between mechanical, biologics, what you would teach your patient about warfarin, the medication that we're going to use. Okay. So then, so we know that acute is something that's going to happen. It's going to have a bad outcome if we don't intervene, and it's usually going to be a surgical intervention, and it's going to be a valve replacement. And in our teaching, our education, our follow-up treatment is going to be based on what type of valve did the patient receive. Okay. So then we have contrast, which is mitral valve regurg that can be chronic. So these patients are going to have they're going to have things that they're going to be asymptomatic for years until they develop some degree of left ventricular failure. Because remember, we know that our structures are going to have to work a little bit harder. Okay, so I want you to be thinking about that. When we is chronic JVD. It can be, because remember that what does left-sided failure lead to? What does left-sided failure lead to? Right-sided failure, right? So in chronic, we usually have enlargement, especially atrial enlargement, right? Because that's where the increased pressure is going to be, because there's just going to be so much volume going in that direction. But we can have left ventricular dilation, we can have left ventricular hypertrophy, and of course, we're going to have a decrease in cardiac output. All right. So it just depends on just how bad it is. Okay, but most of the time that's what we start with. We're starting to have failure here. When our patient starts to develop symptoms, we're in failure. They're in failure. The next one is just something that I'm going to leave for you in the slide deck to look at. It's just a case study, and it goes through the pathophysiology, but we already know that because we've already talked about that. Okay, so this is a little slideshow on just on the prolapse, because we've already kind of talked about that. And I told you that mitral valve prolapse is where the leaflets actually they fall back into the left atria, and they don't close tightly, so we have an incompetent valve here. So what can happen to our patients? They can exhibit dysrhythmias. Usually they're in the form of PVCs. We can have some paroxysmal supraventricular tach. We can also have VTach. It can also cause palpitations. So it could go from something that's pretty benign, which is PVCs or premature ventricular contractions, all the way to VTach. All right, so anything in between. So it can cause some palpitations. It can cause patients to have vertigo. It can cause them to feel lightheaded, like they're going to pass out. Let's see what else. Okay, so chest pain. Infected endocarditis can happen as a result of it. And I want to tell you about chest pain. So chest pain, we don't really know what causes that chest pain, but we have to be careful in these patients. Remember, we have a risk for decreasing cardiac output. So most of the time, these patients are unresponsive to nitroglycerin, and we always have to be really careful about using nitroglycerin in these patients as well. Okay, so I want you to know it might be we might use nitro, but usually it doesn't relieve the chest pain. Okay, and it probably has to do with the papillary. Yeah, it can cause they can have hypotension for sure with the nitrate, because the nitrate causes vasodilation. All right, and we're going to treat these patients with beta blockers. And last week we talked about beta blockers because we want to decrease the heart rate, and we want to decrease the work of the heart with those beta blockers. So we can treat them with beta blockers. It will help to control some of that chest pain, and it will help to control palpitations for sure. And then we might have to have some valvular surgery for mitral valve regurg. So we talked about replacement. What are some of the other things what other procedure could we do for a patient besides just replacing the valve? When would we use a stent or a balloon, you guys? When would we use a stent or a balloon? In what type of dysfunction? Stenosis or regurgitation? Stenosis, right? So tell us what we're trying to do, Paige, when we put a balloon or a stent in there. Tell us what we're trying to do. Open the valve. We're trying to create more space, right? So we want more blood to be able to flow. So we could use a percutaneous balloon valvuloplasty in a stenotic valve, all right? But not in mitral valve prolapse. Now, so what I'm trying to get you to say is that we could try to repair the valve. So we can do a surgical procedure to try and repair the valve. And if not, then we would have to do a valve replacement. That was very rude. Are you guys there? Okay, all right, good. Sorry about that. I told you I'm on the farm today, and it's decent weather right now. I don't know why that just happened to me, but I saw it happening. Okay, so clinical manifestations. We know what's going to happen with our patients with mitral valve prolapse. We also know what procedures can be done for these patients as well. Okay, so patient education. So if your patient has mitral valve prolapse, they're going to need antibiotic prophylaxis prior to any procedure. All right, so dental procedure, surgical procedure, they're going to need to be prophylaxed prior to any kind of procedure. Does that make sense? So if you have mitral valve and you know what, you guys, we're going to follow what Lewis says, and I won't even confuse you about what happens in the real world, but there's a lot of changes about prophylaxis for antibiotic prophylaxis for a lot of things these days. So make sure that when you're in clinical practice, you are up to date with what the literature says about antibiotic prophylaxis. But if your patient has mitral valve prolapse, with regurgitation, we're going to encourage antibiotic prophylaxis, okay? No, it won't, Zenaida. It's going to either be a valve replacement or a valve repair. Because remember, that valve actually is open too much, right? It doesn't close. It doesn't close crisply. So putting a stent in there won't help that. We got a problem with those leaflets. It's not that the valve is narrowed. That is not the issue. Here in prolapse, we have a valve that just is incompetent. It doesn't close. It's like your screen door that won't close properly. Does that make sense? Okay. One of the other things we want our patients to do, and we want them to do, we want to always teach them this, but take medication as it's prescribed. If you're having problems, we're going to talk about exercise here in a second. If they're having problems, and you know, beta blockers, they make your patients feel bad. And so a lot of times your patients, when they feel bad, they want to stop taking their medication. This is not, these are most of the time are not things that we want them to stop, but we can change the beta blocker. We might be able to go with a calcium channel blocker. We might be able to do some other things to help them, but we need to make sure that if they're feeling bad, that they need to reach out to their healthcare provider. Of course, we already talked about a healthy diet. And of course, these guys are already going to be at risk for chest pain and for palpitations. So we want them to limit their caffeine and stimulants. So avoid the over-the-counter stimulants. I think about cold medicines when I'm thinking about stimulants over the counter. And I'm thinking about other stimulants that people use, methamphetamines, cocaine, things like any other stimulant. Okay, so let's not be naive, or also diet pills, things, anything that will stimulate you. Let's not be naive and think that people in our emergency room in our communities are not using illicit drugs. Okay, those are things that we have to always be on the lookout for. Now, exercise. Okay, so you know, we should always be aware. And you as the nurse are not going to tell a patient to begin an exercise program. Even people that are over the age of 40 who are not regular exercises should really seek a cardiac evaluation before they start some rigorous program that they've never they've never exercised before. So they do need to exercise. You know, we're going to for optimal health, but they need to be cleared by cardiology, and they need to be supervised by cardiology. And in the larger communities, you'll see that there's cardiac rehabs all over your city for people who have cardiac disease. So we would never recommend. We personally, we want to encourage an exercise program that's been approved by the cardiology provider. Okay, so but we do want them to exercise, and of course we need to teach them when to call EMS, when to call their healthcare provider. So just like I told you, if my medications are causing me to have a negative effect, I want to reach out to my healthcare care provider. But if I'm having palpitations and fatigue and weakness and difficulty breathing and anxiety, and there's been a change in my health status, we need to teach them to call EMS, because getting in the car and going to the emergency room, especially if it's an acute mitral valve situation, regurgitation situation, it can, as I told you before, it's life-threatening. So we want them to call EMS for that. Okay. Questions so far? We don't have a whole lot of slides left, I don't think, because we're going to move on. And we've already talked about this. We've already talked about that. Just know that there are some people that have a genetic link for mitral valve prolapse. These are slides about mitral valve prolapse, and you can look at them. Okay, so let's talk about aortic stenosis. Remember that we're still on the left side of the heart. So it can, we can have congenital stenosis. And I actually have a friend, he's now 50. He's had 3 valve replacements already. He had aortic stenosis discovered as a child. And so he's always having to have his valve checked out. He has a biologic, which should only be good for 10 years, but he's going on year number 14 with that. So, but you have to have that evaluated every year. It can also be degenerative, or it can be caused by streptococcus, beta hemolytic strep, which results in rheumatic fever. Okay. So the aorta has 3 leaflets, and the problem is that we have a decreased flow, because that valve, the aortic valve, is narrowed. So we don't have as much blood coming from the left ventricle through the aorta. So when that happens, we're going to have left ventricular hypertrophy, because that left ventricle is going to be working harder. This is where it's going to get thicker. This is where we're going to have a decreased amount of blood in that left ventricle, because the inside of the ventricle is smaller. And so we're going to have a decrease in stroke volume, a decrease in cardiac output. We're going to have some pulmonary hypertension and some left-sided heart failure. So these patients, left untreated, have a very high mortality rate. Okay. So what's happening when your patients are not being perfused? They might complain of lightheadedness. They may have near syncope. They may have syncope. They may have chest pain because they're not meeting the metabolic needs of the body. Okay, so, and as aortic stenosis gets worse, the symptoms become more dramatic. So here's the clinical manifestations, or sometimes we call it the triad, which is angina, syncope, and exertional dyspnea when we're talking about aortic stenosis. So these things, what do they reflect? They reflect left-sided failure, right? So usually our patients will start to exhibit symptoms when that opening of that valve is about 1/3 of its normal size. Okay, so it's really got to get narrow most of the time before our patient has some symptoms. Let's see, what does this say? Okay, so the poor prognosis for patients who don't actually have their valve repaired or replaced. Okay, we have to use nitroglycerin very cautiously in these patients, because we can worsen their chest pain, and we're going to significantly reduce their blood pressure when we give them nitro. Why are we going to cause a drop in blood pressure again? There's not less, well, we're going to make it worse, because then we're going to vasodilate them, right? Nitroglycerin causes vasodilation. So they already have a decrease in blood flow, and now we're going to vasodilate them. So we're going to cause even more problems, and they can even become more symptomatic as a result of that. So we got to be very careful about using nitro in these patients. And that's our go-to all the time. Anytime our patients have some kind of chest pain, the first thing that we think about is let's get some blood, let's get some more blood to those coronary arteries so that we can perfuse the myocardium because it's suffering. And actually we can make things worse by giving them nitro. So we have to be really careful with that. Okay. Let's talk about aortic regurg. So now we're still on the left side of the heart, and now we're talking about blood flow that's going to regurgitate through that aortic valve. So the blood is going to go back from the backwards to where? Where is it going to go? Where's it going to go? If it's flowing backward from the aortic valve. Okay, so I want you to be thinking about it. Okay, so it's going from to the left ventricle. Yes, from the left ventricle. So it's gonna it's already being pushed out from the left ventricle to the aorta. Remember, we have ascending, the arch, and then descending and out to the body. So when blood comes out of the left ventricle, it goes through the aortic valve. Yes, meant the heart, and then it goes to the ascending aorta. Well, if the aortic valve is incompetent, that blood flow is going to go back to the left ventricle. And of course, depending on how significant it is, it will back up all the way to the lungs. Okay. Yes, Carrot.
Professor, can you please ask that question again so I can kind of put what you just said together?
Oh, let's see if I can. Let me go. Okay, so I think I asked you where blood is going to flow, what chamber, I should have said, what chamber is blood flowing back into? So if it's coming from the left ventricle, going through the aortic valve, and it's going into the ascending aorta, if the valve is incompetent and it doesn't close properly and it's left open, blood will retrograde or backflow back to the left ventricle. Depending on the severity of it, it can push blood all the way back in the system. This is where you would follow your blood flow all the way back, which would take you out to your superior and inferior vena cava. Does that make sense?
Yes, ma'am. Thank you.
All right. You're welcome. All right, so where was I? Okay, so we have acute aortic valve regurg, and then we have chronic aortic valve regurg. So some of the causes when we're talking about acute, it can be infective endocarditis, which we're going to cover next week. Could be some kind of chest trauma. It could be aortic root dissection. Could be, primary disease of the aortic valves, like I told you before, in congenital. This is a life-threatening emergency. Remember that this is the aorta is the largest vessel. Think about what the aorta does for us. Oh my gosh, think about it. It delivers a massive amount of blood supply, oxygen, and nutrients to the heart, to the brain, and to the rest of the body. All right. So that structure is super important. And if something happens to that area, let's say you have trauma or you have an aortic dissection, it's a life-threatening emergency and people are going to die. Okay. People are going to die if we don't do something about it. Chronic aortic regurg can be a result of rheumatic heart disease, rheumatic carditis, congenital bicuspid aortic valve. So here, that means that the patient would be born with 2 leaflets on that aortic valve rather than the 3 that everybody else is born with. Syphilis can also cause aortic valve regurg. That's why we check for syphilis in a pregnant woman and also in a newborn. And then chronic rheumatic conditions such as things like certain arthritises, for example. Those are things that can cause chronic, anything that's inflammatory can cause leaflet issues, okay? So what's happening here? There's backflow of blood. We already established that from the ascending aorta into the left ventricle. There can be, these are things that we've already talked about. Of course, there's going to be decreased myocardial contractility, pulmonary hypertension, and right ventricular failure. So remember that left ventricular failure leads to right ventricular failure. The pressure always backs up. So these patients, what are they in? This is acute, okay? This is acute aortic regurgitation. They're gonna be have a very difficult time breathing. They're going to be short of breath. They're going to feel short of breath. They're going to be tachypnic. Their respiratory rate's going to be up. They're going to probably be hypoxic. Their SpO2 is going to be down. They're going to experience chest pain, hypotension, left ventricular failure, and cardiogenic shock. All right, so we already learned about cardiogenic shock, and we know that this is a life-threatening emergency where we could have cardiovascular collapse and subsequent death. And we know that people that have cardiogenic shock have a high mortality rate. Chronic, this is chronic. So sometimes these patients, you know, they live with a chronic aortic regurgitation. They may be asymptomatic for years, but as time goes on and they have failure, then their left heart failure, they're going to become symptomatic. So they're going to have exertional dyspnea, just like we talked about before. When they're getting up to do things, they're going to be short of breath or have difficulty breathing. What is orthopnea? What is orthopnea? Short of breath when? Difficulty breathing laying down. Well, that's right, actually. Okay, so when you're laying down, you have a difficult time breathing. So if you have a patient that has heart failure and you want to know if they have orthopnea, what's a question you, the nurse, are going to ask them? So if I'm having difficulty laying down at night, I can't breathe when I lay down flat in bed, what might I do? How many pillows do you sleep on? How many pillows do you sleep on? Okay, so that is a question that you ask for orthopnea. How many pillows are you sleeping on? That gives you an idea. Now, there are some people who just like pillows, but because basically what they're trying to do is they're trying to elevate the head of their bed, right? But they don't have a fancy hospital bed where they can have a remote control that puts them at 30 degrees or puts them at 45 degrees. So they're going to use pillows to prop themselves so that they can increase their lung capacity and expansion so that they can breathe better. Does that make sense? Okay, so now this should say paroxysmal dyspnea or paroxysmal nocturnal dyspnea. What is that? Difficult breathing at night. Yes, both you guys are the last 3, Brandon, Racine, and Mo, you got it. So I'm going to tell you guys something personal. I have AFib, So before I was diagnosed, this used to happen to me. I would have paroxysmal nocturnal dyspnea. And I would wake up in the middle of the night, and I swear to you, it was like somebody was choking me. I couldn't breathe. You're gasping for air. So it is a very horrible thing to have paroxysmal nocturnal dyspnea. So patients who have that, you need to be paying attention to them. If they complain of waking up in the middle of the night and they are short of breath, have difficulty breathing, feel like somebody's choking them. These patients can also have paroxysmal nocturnal dyspnea. But how am I managing? Are you asking about me? Oh, I'm cured. I don't have I don't have AFib. I had a procedure to hopefully it never returns, and when we get to module number 4, you'll understand some of I had an ablation, so my electrical system is working fine right now. But stress is a terrible thing, so got to always be careful about that. Okay, so they can have angina even though in aortic, they can have angina. I don't know what I was going to say about aortic. And these are some of the other things that they can have. Okay, they can have a soft or absent S1. They can have S3 or S4, depending on how bad it is and how much hypertrophy they might have. And they can also have a murmur. Okay, so we're almost to the end, guys. I know I kept you a long time last time, and I don't want to do that today. What about the tricuspid and pulmonic valves? I told you that people can have problems with tricuspid and pulmonic. Those valves are on the right side of the heart, and not that the right is any less important than the left, but they are less common. Stenosis occurs more frequently than does regurgitation. So let's talk about some today. Okay. Here are some of the causes that that can happen to patients that have tricuspid. So that's the valve that separates the right atria from the right ventricle. Infective endocarditis. So by the time that we come together next week, some of these things should make sense to you when we talk about infective endocarditis, rheumatic fever. And these patients are patients who have intravenous drug use are at risk for tricuspid valvular stenosis. So basically, we have a narrowing of that tricuspid valve. So we have blood flow that's decreased coming from the right atria to the right ventricle, and it's going to cause that right atrium to enlarge because it's working harder, right? Everything is flowing, is not getting down to the left ventricle. So it's creating an enlargement. And so we're going to have an increased systemic venous pressure because the blood is backing up into the venous system. So what kind of heart failure symptoms or signs and symptoms are you going to see with these patients? What kind of effects are you going to see with these patients? Remember, we're on the right side now. Switch your brain from left to right. Ascites, edema, peripheral edema. What else? JVD. JVD. You can also have splenomegaly. Somebody said ascites, but hepatomegaly, you can have that as well. So those are the kinds of things that you're going to see in a patient with tricuspid valvular stenosis. All right. Pulmonic stenosis. Okay, so this is the valve taking the deoxygenated blood into the lungs. So almost always pulmonary stenosis is congenital. Patients with right ventricular hypertension, they can develop right ventricular hypertension and hypertrophy, which makes sense. Your patients will be fatigued. They can have a loud murmur when we're talking about pulmonic valve stenosis, valvular stenosis. So when we are talking about valvular heart disease and we're talking about diagnostics, so this is what Lewis tells us, right? It tells us that the CT is the gold standard, and that's for evaluating aortic disorders usually, because we have better things that we can visualize with. What is the procedure here or diagnostic test here on this slide that would give us the most direct information? The most direct information about the heart, about the valves, about pressures. I just told you. I just gave the answer right here. Actually, the heart cath. The heart cath is direct visualization. So you either go up through the femoral, which is least common now. You go up through the radial artery and you go into the heart, and you can directly visualize the structure. You can measure the pressure in each chamber. You can look at the valves. You can actually inspect them. You can measure pressure, if I didn't already say that. You can look at the size of that valvular opening. You can actually see everything that's working. Have you guys been to the cath lab yet? Is that one of your opportunities? No. Dang. If you guys get an opportunity to go to the cath lab, oh my gosh, it might be hard for you to actually see what's going on. Oh, you did? So Paige, did you get to see the structures? Did you get to see, it's where I want to end up, and I love, yes, it's fabulous. You can actually see everything. So a heart cath is direct visualization. You can actually see it on the screen. Another way of direct visualization is the transesophageal echocardiogram, where you go down obviously through the esophagus, and you can also have direct visualization there. And there's a lot of valvular problems, a lot of PFO that can, it's on echo. All right, great. And so that's great. So to me, the best way to see these to measure and to see defects is heart cath, TEE, and echo is also another great way, but it's not direct, it's indirect, right? Because it's ultrasound, so it's showing from the outside, but the echo gives us a lot of information. It can evaluate the structures, it can evaluate the valves. We can see, they can measure the thickness of your muscle. It can show you the size of your chamber. It can tell you how well things are functioning. It gives you ejection fraction, gives you a lot of information. So I'm glad you guys are getting to see some of these things, because when you actually see them in clinical, that we should be working together to marry some of those things, so that whatever we're talking about here in didactic, you should hopefully be seeing in clinical, because that's how you imprint, that's how you make that connection. And that's why we're building this firm foundation right here. So, and also chest x-ray. Chest x-ray is really going to tell you if you have backflow into the lungs, you're going to have pulmonary congestion, right? And of course, your patient will exhibit signs and symptoms of pulmonary congestion, and your heart will be enlarged. And we already saw that on one of our x-rays. So when you're looking at chest x-rays, if you are in the hospital, if you're doing clinical, ask whoever you're working with, can we look at some chest x-ray? That's how you're gonna, once you get exposed to them, that's when you're gonna start learning how to marry your patient's symptoms with the diagnostic study that are being collected. And the last thing is just part of that case study. So here, these are some things that I want you to be thinking about. I want you to be thinking about treatment modalities. I want you to go back and refresh your memory on some of the things that we use to treat and control heart failure, because these things left untreated lead to heart failure. So what are some of the drugs? What are the vasodilators that we use? What are some of the positive inotropes that we use? Like, for example, digoxin. We also use diuretics. Which diuretics do we use? We use beta blockers. We also use diet to control heart failure. And I already told you we would be talking about a low sodium diet. We can also, sometimes we will use anticoagulant therapy, warfarin. And if you have atrial fibrillation, we won't use warfarin. We'll use another type of, they're called DOACs. Do you guys remember the DOACs? Do you remember what those are? That drug class? I just told you last week to learn the generics, and off the top of my head, I honestly do not know the generics for Xarelto and Eliquis. All right. And then we would use antidysrhythmics if our patient has a dysrhythmia. All right. We talked about the procedures. We talked about the valvular replacement, valvular repair, percutaneous balloon valvuloplasty. Okay, so those are some of the things that are left on the table. So today I've been contemplating about whether or not you guys think you need a review before exam 1. What do you think? All right. Okay, I'm going to try. Oh, okay. All right. Well, that I'm here for you. So I was just thinking about what I could, some of these things that we just can't cover in one session, how I can also cover them. And I might be able to do some of that in a review. So we'll just have to figure out when we can do that review. Okay. Any questions before we go today? Any questions at all? Okay, you guys, thank you so much for being flexible. Thank you for coming today. I will see you next Wednesday at our regularly scheduled time, which is at 4 o'clock Central Standard Time. Please reach out to me if you need to see me in office hours. Please reach out to me if you have questions or concerns. If you are in tutoring, please continue to go to group tutoring. If you need more individual support, please seek out an individual tutor. All right. I do love Lilo's group tutoring sessions. But if you need more individual tutoring, please seek out somebody else, because sometimes the different people have different ways of explaining things to you. So if you need your individual tutor, please reach the Student Success Center so you can get started early. Okay. Thank you guys. Keep learning. And just be the best that you can be. All right. Have a great weekend. Study hard. Carve out enough time.